all being on Friday. So I guess they say that will be going. Welcome everyone. Thanks for those of you that have joined early. We'll just give people another minute or two to drop in and then we will kick off. I guess we should kick off because we've got quite a lot to fit in. So welcome everyone and thank you for joining. I'm sure we'll have a few more people dropping in over the next few minutes. For those that don't know me, my name is Helen Williams. I am a clinical lead for CVD in South East London ICB, and it's really great to welcome you to this webinar. So we've got a few things to cover today. We want to, I'm just going to go quickly through the data. Where are we in South East London? Then we have Kessel, who are going to talk about some of the next steps you can take to improve blood pressure management. We've got Sian Howell and Margaret Senbanjo to talk on that. And then Ash Khan and Raj Mathari are going to talk about community pharmacy and opportunities for integration around blood pressure management. And then we hope have time for a Q&A. So if questions arise during the talks, do drop them into the chat box. Astrid, at the moment we've got your webinar screen, not the agenda screen showing. But I'm going to share my slides anyway to start going through the data set. Let me share my slides. If I can do that.
Okay, sorry about that.
Don't worry. It's hard when you've got two screens to work out which one's showing. Right, let me find the right one for me. So all of these sessions, we've tried to start with looking where we are in terms of the data, which is what I'm going to do, and reminding ourselves what we have been asked or tasked to do at a national level. So our NHS England objective for 24-25 around blood pressure is to achieve 80% control of blood pressure treatment targets, and according to the patient's age appropriate target. So that's what we are tasked with delivering, and we know it's a very difficult ask, particularly reflecting on the impact of synovitis on the chronic disease work So we are very cognizant of that. So if we first look, I'm just going to show you graphs to the end of the last financial year and then show you where we are up until the last set of data we got at a national level from CVD Prevent. So this indicator is looking at people with hypertension, so all the people on the GP hypertension registers who've had a blood pressure reading in the last 12 months up till March 24. So 87.9% of people in South East London had a blood pressure check. Of those that were on the hypertension register had a blood pressure check in the last 12 months. And the average in England's pretty similar, 88.62. And you can see we're pretty close to matching the England average on this graph. We do always see, if I can make my next slide appear, a deterioration in the first quarter of the year. It's seen nationally, but ours always seems to be slightly bigger than the national deterioration, which is interesting, which means we've obviously got more to do over the course of the next 3 quarters to get back to the position that we were in at the end of the year. So it's whether we can do anything earlier to try to prevent that happening. This is probably the most important graph in that it's looking at the percentage of people with hypertension who are treated to achieve target. And you can see we pretty much match the England average at the end of March last year, with a significant increase in particular in that last quarter. So great to see that, and we reflect and recognise that that's the work of people on the front line. But similarly to the previous indicator, we've seen a slightly bigger drop-off in the first quarter of the year than the rest of the country, which just makes our lives a little bit more difficult in achieving towards the end of the next financial year. And the target is still a long way away from what anywhere has really got to. England was 71%, we were 71%. We're trying to get towards 80%, and we do recognise that is a really difficult thing to achieve. But we think there are maybe some things we can do to support delivery. One of the things that has become really apparent from the national data set is that our younger patients, of which we have probably a greater proportion, particularly in the inner London boroughs, our younger patients with hypertension are the most poorly treated. And there's lots of reasons behind that. It's not necessarily our fault as such, but you can see that under 40s with hypertension, only about half of them get treated to target. The 40 to 60-year-old cohort, only 63% getting to target. Now, you might think that might be a small proportion, but it's probably at least 50% of our entire cohort. So it's a really big group, this, that we could potentially, if we can improve uptake and adherence in this cohort, have a big impact. Our 60s and above are generally reasonably well managed, 80s and above very well managed, and the 60s to 79s at 73%. So it just might give us an idea where we might want to focus a bit of extra time and support to try and get those younger people through the door. And it might not be through your door for a blood pressure check. It might be through the community pharmacy door. We'll hear more about that later. At a national level, only 40% of the people in the under 60s cohort had not had a blood pressure done in that year. So partly it's about monitoring. Some of them will be well controlled, and then partly it's about treatment. If we look at our local data, it sort of tracks CVD Prevent. It's a slightly different indicator, so it's not exactly the same as the CVD Prevent data, but this shows us what our overall population is achieving monthly over the past couple of years. And you can see where we were in March 23, 65% or so controlled, went up at South East London level to nearly 68% control, and that was reflected as 70.7 in the CVD Prevent audit. Challenge for this year is we've seen that greater decline month on month, pretty much for the first 6 months of the year. It might have just plateaued in the last September to October period, and we've dropped about 4% in terms of blood pressure control April to October this year, compared to only 2% at the same time last year. So a bigger challenge for us to make up, bearing in mind the stricter target. And I'm just going to whiz through the more detailed data from our South East London data set. So we have seen improvements across all the place-based teams, and you can see here at the individual places, and the range between 57% control to 62% control, and that gap has narrowed over the course of the last year. And at a PCN level, the lowest performers are at 52% and the highest at 68%. You can see the top performers there. And then right down to practice level, the poorest performer at 41% up to 87%. So huge variation, and possibly opportunities for us across these practices to share those that are doing well, what are they doing differently, and how can the poorer performing practices adopt those approaches. And I think Kessel will talk to that as well later. Just what the opportunity is reflected in this graph called the size of the prize for South East London, showing us what happened in COVID and where we are now. So before COVID, we were at 70% control. We dropped to 46% because of the lack of face-to-face appointments. At the bottom of the chart, you can see March 24, we got to 70.7, and we've seen quite a significant drop off in June, down to 64.9%. And what the line extending beyond June 24 shows you is the potential. Could we get to 74%, which would mean an additional 20,000 patients treated? And at the bottom, the number of events that would prevent for South East London. Could we get to 77%, 28,000 more people treated to target? And could we even push towards the 80%? Every percentage point we make in that direction is reducing the risk of heart attacks and strokes. And that's what we're ultimately trying to do. So I think there are opportunities, and the future talks will talk a little bit more about that. But from a detection point of view, one of the QOF indicators is that adults over the age of 45 should have a blood pressure check in the prior 5 years. And there are opportunities in GP practices to recall those patients, to refer them to community pharmacy for a simple blood pressure check, or if they've got a home device, maybe request a home blood pressure check. Probably less home devices in people who haven't had a diagnosis than there are in people who've had a prior diagnosis. There's that cohort of patients in general practice who we know have a high last recorded blood pressure, but they're not on the hypertension register. This is still part of the BCN-DES contract. Again, recall for diagnostic tests in-house or refer to community pharmacy, because they can do a repeat blood pressure check. If it's still high, they can do the ABPM. There's the monitoring cohort, patients who already have a diagnosis but haven't had a blood pressure check in the last 12 months. They automatically fail QOF for that year. And I've highlighted earlier the adults less than 60 years old are a particularly important cohort. Again, recall to the practice or ask for a home blood pressure. 30 to 40% of patients have access to home blood pressure monitors, or refer to community pharmacy for a routine blood pressure check, which would get then communicated back to the practice. A lot of these patients that haven't been monitored in the last 12 months will probably come in on target and therefore don't need additional follow-up in the practice. And then there's finally the treatment. So adults whose last recorded blood pressure is high, so not treated to target. Kessel will talk about the searches they have, which will prioritise patients based on risk. We have the Kessel guidelines for management, support for lifestyle and behaviour change using your wider workforce, so your social prescribers, your health and wellbeing coaches, and then greater opportunities for medicines optimisation and adherence support. So that is all that I was going to say today. I will stop sharing my screen and I'm going to hand over, pretty much on time, which is a miracle, to Kessel to talk about their next steps in blood pressure management.
Thanks very much, Helen. Can you hear me? Is that all right?
Yeah,
I'm
we can
hoping
hear.
that Margaret's on, but Margaret's on a slightly different invite. Margaret, are you able to turn your camera and unmute off, because we're supposed to do it together? And if you're not, could Astrid perhaps send you the speaker's invite? So what I will do, because I can't hear Margaret and I can't see her, I'm going to share some slides, and I'm hoping by the time we get to Margaret's bit, she's managed to get in as a speaker. So let me just share my screen. Hold on a sec. Bear with me. Okay. Here we go. Hope everybody can see that, and I can't see people now apart from you, Helen, so you'll have to let me know.
We can see,
great.
Although it doesn't quite fit the screen, which is because it's not a PowerPoint, but we'll work it out. If we can't see the bottom, I'll let you know. Okay,
fine. So hi, my name's Sian Howell. I'm a GP in Lewisham and I'm part of the Clinical Effectiveness South East London team, and we're going to talk a little bit about what support Kessel can offer to practices and PCNs around hypertension. So what we're planning to cover today is our general support for practices, a little bit about Synovis and how that's impacted on hypertension for us all. Let you know about the updated hypertension guide, which is going to be with you very soon, and then a little bit about the South East London Cardiovascular Disease Inequality Scheme, which has just been, for the third year, has just been sent out details through the bulletin. So I'm going to kick off. I'm just hoping, can I just check that Margaret's not around, because Margaret was going to present this, but I think I'll plod on until Margaret's face pops up and lets me know that she's around. So apologies, Margaret. If I make that a bit smaller, can you then see the full screen? Does that work, Helen?
Yeah.
Sorry, yeah, that's perfect. I was on mute.
Great. Okay. So just to remind you, on the left-hand side, we talk about the Kessel methodology, and we apply this to a range of clinical conditions, including hypertension. So what we do is we prioritize a condition that we know matters for our patients and that we can impact on in primary care. We create a guide, and we do that collaboratively with partners across the system, and that describes the right thing to do. We launch the guide through educational events so people know about what's good practice. And so for hypertension, we've got at the moment, we've got one for each borough, but we're bringing those together. A little bit more on that in a minute. We've also got a hypertension resource pack for non-clinicians, which is really helpful for supporting the non-clinical members of your team, for using pop-ups and supporting patients in their hypertension care. And it's got lots of really good examples of things you could do for quality improvement. We then make sure that the ARDENS template on your system aligns with the guidance so that you can enter the data correctly. And then that allows the data to be pulled out and presented in the dashboards, as Helen's just shown you. And we work closely with the BI team to try and reflect practice and PCN needs for data in the hypertension dashboard. And then we come out to facilitators and clinical leads in each of the boroughs will come out and share your data with you, let you know how you're doing, and support you in improvement work. We've got the QR code there, but you can either just Google Kessel or use the QR code. We will share the slides later. So moving on, I'm going to talk a little bit about the impact of Synovis on hypertension. So Helen very helpfully shared some slides which showed us where we got to up to June. Now, June was about when the Synovis incident hit across South East London. So that dip that we've seen up till June was before we started to think about the impact of Synovis. So as we know, we had the ransomware attack on the 3rd of June. All pathology services were taken offline, and the infrastructure had to be completely rebuilt. And over those summer months, we had these mutual aid agreements and arrangements across the different boroughs with different arrangements. Everything is back to normal now. During those summer months, we were doing urgent blood tests only. This has had a very significant impact on how we could deliver our long-term condition management. We were using an ARDENS template for delayed tests, and we're now in the process of working through the backlog. So I'm going to share a little bit of data. Now, what I'm sharing now is a kind of snippet of a longer webinar that we did earlier, a month or so ago. So if people want more detail, I will share the link for the longer webinar. But what this slide looks at is our hypertension performance across the 6 boroughs of patients hitting their QOF target. And the blue line shows September last year, and the red line shows September this year. So it does show that even though we've had the Synovis ransomware attack, we are still performing a little bit better across all 6 boroughs, both in our under 80s and our over 80s, which is encouraging. And actually, when we compare this to how we're doing in diabetes, we can see that hypertension has been less impacted on Synovis than perhaps diabetes, because for diabetes, you absolutely have to show for the 8 care processes that you've done their renal function, for example, you've got their lipids. So you can see, again, the blue line last year, the red line this year, really, really big impact of Synovis differing across the boroughs, with the higher performing boroughs having taken more of a whack, both across the 8 care processes, slightly less so with the triple target. What the data doesn't tell us is about the rate of improvement. So Helen's shown us a sort of slightly wavy up and downness of how we're doing, but that we're generally getting better and better. And the data I've shared shows you that as well. But what it's not telling us is, has our rate of improvement slowed down? And I think we're going to need a few more months data to have a look at that. It also doesn't tell us how we're doing compared to our peers. So how big has the synovitis impact on us been compared to, say, the other ICBs across London or nationally and unnational? So I think we're going to have to wait for that CVD Prevent data, which tends to be updated every 3 to 6 months, to see the impact of synovitis over time. And also what it doesn't tell us, particularly for hypertension, is how has the quality of our care been impacted? We might be having patients hit target, but have we checked their ACRs to pick up any renal damage? Have we been doing their U's and E's as regularly to make sure that we're picking up again for renal failure or any impact to their ACEs? Have we managed to check their lipids, do their Q risk assessment, and start them on the right treatment for that? So we don't actually have this data at the moment to compare. So I think overall the message is we're kind of probably doing okay on hypertension, but I think we need to be very cautious because we'd already dipped down a little bit in June, and I think our work is really cut out for us over the next sort of months leading up to the end of the QOF year. Now there is information on the CellNet SharePoint site, particularly around restoration and recovery, and the ICB has talked about ensuring that practices have a certainty of income and flexibility to prioritise their workload. So if people want to see the ICB response, particularly around incentives and payments, if you go onto CellNet, you'll find that, and we've got the link there. So what we talked about when we did the webinar a month or so ago about in recovery, and I think a lot of practices and PCNs will already be doing this, but I'm just going to touch on some of that for the benefit of this webinar, is the things that you needed to do as we start to recover long-term conditions after the synovitis incident. You really, and we sort of divided up, thinking about your capacity and pathology pathways, running for searches for your patients who've been waiting, and then using the existing tools that we have and that we use for hypertension, and then thinking about perhaps new ideas of managing the backlog that we've got across all our long-term conditions. So we could think about your capacity and pathology pathways. What we suggested is using some process mapping, and if you want any help with this, please reach out to your Kessel facilitators. But recognising as soon as phlebotomy increases, then we've got more results coming back in. That generates more work for your back office teams to process those, more work for your clinicians to review those results, and then more patients coming in or needing contacts. So we have to recognise the kind of impact at every stage. So it might be worth sitting down with a small group of your team representing both clinicians, front desk, back and admin, to really think through how you can work through that backlog and think about the impact at every part of that journey. Now, many people were using the Ardens report, which showed when patients had been delayed. And this slide here shows you where you can run the searches on that report and how you can download those at a practice level to identify your patient lists. You can then sort them by how long patients have been waiting, or start to go into individual patients. But I think for practices, I think a lot of people are doing this already and beginning to work through their lists. It is quite tricky because some people may have come back and been sorted already. But anyway, there's some guidance there if you do need that. Then there are some other searches that you might find helpful, and these are not particularly related to the synovitis attack, but we thought that they may be helpful. These are particularly around diabetes and the treatment targets, but it shows you where you can find the different searches. So apologies, I should have put the hypertension one in here, but I think I slipped in the diabetes ones. But what we have here is the UCLP stratification risk tools, which I think many of you are familiar with. And these are searches which are available in Ardens on your EMIS system to prioritise your patients with hypertension. So priority 1 is these patients with very high blood pressures that you need to kind of make sure that you've got a plan in place and you're in contact with. And then priority 2, priority 3 and priority 4. This can help either prioritise bringing them in or working out who's best in your practice team to see these patients, with the higher priorities needing to see more senior clinicians than perhaps the lower priority patients. And again, there's some guidance here of where to find these searches so that you can identify the patients in your practice. As I said, that's a sort of an abbreviated version of the longer webinar that we did, and I put a link here if you want to look at that in more detail, or you can reach out to your facilitators to support. Now I'm hoping that Margaret is now on the call and magically appear.
Sorry, I wasn't able to unmute, and I don't think
I
you
could
could
see that
me.
you were in the wrong bit, so that's fine. I'm really glad you're here, Margaret, because Margaret and Grace have been, well, I'll let you introduce yourself. We've been working on updating the Kessel Hypertension Guide, so I'm going to hand over to you, Margaret, for this bit.
Yeah, awesome. Hi, everyone. So I'm Margaret. I'm a GP in Lewisham. I've been here for about 5 years, also trained here. So you guys are lucky to still have me. No, I'm joking. Before I move on to the hypertension guide, Sean, there was a comment in the chat from Bromley saying that they've been told to only request urgent bloods. And I just wondered if, to your knowledge, if that should still be the case, or if actually things have eased up with synovus and they should be going back to sort of normal sort of requesting behaviour.
Apologies, I didn't know that, Bromley. So I guess I'm not really speaking from the ICB. I thought everything was back to normal, so apologies. I think the best thing to do is to go to the CellNet webpage for updates. But I thought everything was back to normal, so apologies, Bromley, if you're still waiting for that.
Yeah, same here. Okay, awesome. Are you able to go to the next slide, Sean? Awesome. So basically, over the last sort of few months, what we've been working to do is trying to consolidate the 6 separate borough hypertension guides that we had into one South East London guide. So that approach seems to have worked quite well for CKD and for asthma, and so we were just continuing the trend. So consolidation plus a minor update on some things that have changed since the guides were last written. Next slide. So in our guides, they generally follow the same format, which hopefully makes them easy to use. So we've got the standard sections which talk about why focusing on hypertension, how to diagnose it, and the importance of cardiovascular disease and Q risk. We also go on to talk about investigation, treatment, and as well including the lifestyle supports, as well as the local pathways. In this particular guide, though, we have added some new content. So there's increased information around health inequalities and hypertension. So we've added information about mental health and learning disabilities and deprivation, and how they also affect people who have hypertension, or how they can be sort of sometimes risk factors for worse outcomes. Then we've got another new page, which is a hypertension and pregnancy page, which we've worked very closely with some consultants at Gaz St Thomas's to produce this page. So hopefully you'll find that really helpful. It covers people planning pregnancy, people who are pregnant, and the postpartum period where people are breastfeeding. And then what we really try to do in our guides is increasingly capture the fact that lots of other advanced care practitioners, people essentially apart from GPs, are increasingly involved in hypertension management. And so some of the guides has areas where there's a bit more explanatory. So you might want to be able to use these with maybe pharmacists or nurses or other people who are involved in hypertension care. So we've got those sections for people who have got that need that added additional background. But for those people who are sort of more au fait with hypertension and just want to use the guide for sort of double checking best practice or referral guidance, all the information is easily signposted in the contents page, so you can get to the bit of the guide that you need the most.
And Margaret,
I'll hand back to you. Yes.
Yeah, I was going to say, when is it going to be ready? When are people going to be able to see the new version?
So the guide, we're just currently just ironing out a couple of small details with the medicines management team. So we're hoping to have it sort of resolved and available for use by the end of this year. But as soon as it's live, we'll probably put something out in the newsletter so that people can sort of see it on our webpage and get to using it.
Thanks. I'll carry on then. Just the final bit of our presentation is to talk about the Cardiovascular Disease Health Inequality Scheme. I hope people know about it, but there's just a bit of a reminder. We're about to go into the 3rd year of this scheme. Now, this is a scheme where Kessel, along with the Health Innovation Network, the HIN and King's Health Partners and the South London CVD Network, put in a bid for funding to support hypertension recovery initially after COVID. And it has 2 parts to it. It's got a practice and PCN component and a patient and community component. The first year of and each year, so year 1, year 2, year 3, we've asked practices and PCNs to engage in a quality improvement project that works for them and for their patients and is supported by data. So in year 1, we said focus on hypertension. In year 2, we said we'll focus on other cardiovascular risk conditions such as chronic kidney disease or atrial fibrillation or diabetes. And what we're suggesting as we go into year 3 is the quality improvement program, but really thinking about cardiovascular disease in a multimorbidity context. So thinking about those patients who overlap with hypertension, diabetes, atrial fibrillation and chronic kidney disease, and really thinking about how we can offer a sort of joined up approach to these patients and what you'd like to test in your practice or your PCN. So there's some funding available to practices who choose to sign up to this, and the expression of interest letter has gone out in the bulletin, and you can also find details on the Kessel webpage. The funding depends on engaging in the project, the size of your PCN, some recognition of deprivation, and also how many PCNs signed up, because it has to be distributed. And there will be ongoing support from the Kessel team, who will bring you data support and help facilitated shared learning across practices within a PCN. So please do use this to try and think about what's right for your practice and your patients. Now, the other component which people may be less familiar with is the community engagement component of the cardiovascular disease inequality scheme. And I've just done a little timeline here because it shows it sort of developed over time. So 4 years ago, Kessel was involved in a Pathfinder project where we were working with partners across London to say, how can we use data to really improve hypertension care for our patients? And we worked with an organisation called Mabadiliko, which is a Black-led organisation in Lewisham, who undertook a great insight report with sort of seldom heard groups to say, what are the barriers for you receiving good care around hypertension or having hypertension detection? And this insight report kind of pointed out sort of trust issues between communities and clinicians, and also access issues. So things aware of in general practice. And one of the recommendations was that were there more community-based clinics for hypertension detection and education that would help address some of these trust and engagement issues. So using some funding of the CVD inequality scheme, Mabadiliko were commissioned to develop a protocol jointly with clinicians and with patients and community groups to develop a community-based clinic targeting risk communities, which they did in 22-23, and that worked really well. And so we came out of that saying, well, that's great. We know you can deliver it, but how could we support other people to deliver a sort of a co-developed service? So what they have done is Mabadiliko have developed an educational tool capturing all of their learning of working with communities and clinicians. It's almost a sort of a resource pack for people wanting to do the same, and that should be available. We're in the sort of final touches of finishing that off, but that should be available certainly within the next month. And then what we're hoping to do is use some of the 24-25 funding to support community groups to work with PCNs to test out the educational tool and see if this is something that can be delivered in different parts across the South East London landscape. So that's a bit of a rattle through. Everything that we've talked about today is available on the Kessel webpage. So just Google Kessel or email us. And if you would like some help or support in any sort of cardiovascular disease or any of the Kessel areas, please reach out to one of your lovely Kessel facilitators. We will share this pack, which has got all their emails on, but you can also just see the generic email address on our webpage. I think there's time for questions and feedback at the end. So I think I'm going to stop there because I have run slightly over. Apologies.
No, that's really great, Sian and Margaret. Thank you so much. We are going to move on, but we will have time for a Q&A. So do drop questions in the chat. So I'm going to invite Ash, who I can see is on the line, to come and talk to us about the community pharmacy work that's going on around hypertension. I'm not sure whether Raj Matharo is joining him.
Thanks, Helen.
Oh, there you go.
Hopefully you can hear me. I'm Ash Khan. I'm the community pharmacy integration lead here at South East London ICB. Raj is on the call. I think he may have the same problem that Margaret did earlier, trying to get onto the being able to unmute his mic. I'm not sure if you can. If you can, Raj, just say yes. If not, it'll be silence. I think he can't go on at the moment, so I'll continue, and then I think he'll just add into the chat as he can.
I think I've just tried to sort his mic out. See if you can unmute now, Raj.
Yeah.
Good.
Oh, fantastic. That means you can chip in, Raj, when you like. Okay. So yes, myself and Raj, who's the Chief Executive Officer of the Community Pharmacy South East London, which is a local pharmaceutical committee that represents all of our 325 pharmacies across South East London. So I think we've got about 10 or 15 minutes to cover quite a lot of things around community pharmacy. So we'll briefly cover an overview of what the community pharmacy hypertension screening service is, a bit around what they've actually delivered and achieved over the last few months since April, what the data looks like, and then a little bit around what the opportunities are to try and integrate and increase the delivery of blood pressure checks through community pharmacies. And lastly, more excitingly, I just want to just put on your radar the Independent Prescribing Pathfinder program, which Helen's also been involved in, that might show us the future of what it might look like with pharmacies actually doing much more than just blood pressure checks, but actually doing some of the prescribing and management of blood pressure control as we move forward in the next 5 years or so.
Ash, can you go full screen if you can? We're just
Yeah,
on the...
Sure. Has that done that?
That's perfect. Yeah, that's just easier to read.
Fantastic. I don't want to repeat all things Helen's already said, but some of the data here that shows that this isn't a static picture. According to the Kessel data, there's over 160,000 people in South East London that are still undiagnosed. So certainly not a static picture. There's a whole pool of patients that still, or a whole pool of people that still are out there with hypertension that need to be diagnosed. And we know from evidence that even reducing by a small amount in their blood pressure, there's a huge amount of beneficial outcomes for those people. Certainly, there's a lot more work to do. And as Helen mentioned earlier, there's ambitions to be reached by 2029, not only in finding these people with undiagnosed hypertension, but also treating to target all the people that are diagnosed. So there's a huge amount of work to do, and this was recognised last year in the delivery plan for recovering access to primary care. Certainly there was a specific section in there about how community pharmacy can contribute towards this, and certainly a specific area around increasing the number of blood pressure checks that community pharmacies are doing across England to support the hypertension targets. So certainly it's recognised nationally the role of community pharmacy that has to play within this hypertension arena, and certainly the data will show you that our pharmacies in South East London have been doing a tremendous job in doing that. So what exactly does the community pharmacy service deliver? Well, the service specification is aimed at those adults over 40 years old with no diagnosis of hypertension. So this is your real target audience of undiagnosed hypertensives within our communities. They can also check the blood pressure for those under 40 years old if they have a family history of hypertension. Certainly within our population, and I think Helen would agree that there's a certain part of our population where hypertension it is occurring under the age of 40. So I think there's opportunity for pharmacies to pick up those of our residents in that category as well, and certainly from not just the walk-in patients, but also from a general practice perspective, they can actually refer anybody of any age with or without a prior diagnosis of hypertension to a community pharmacy. So certainly there's a real opportunity to use community pharmacies to reduce some of the workload that general practice has, and certainly pick up some of the targets that they need to achieve through the community pharmacy sector. There are certain exclusions. There's a general exclusion of under 40, but I've mentioned the exceptions above already. And those are already being regularly monitored for their blood pressure, also excluded as well, as are those with a history of atrial fibrillation or irregular heartbeat. Occasionally, pharmacies may not be able to provide the service because the cuff sizes that they have aren't suitable for their patients. Particularly for very large patients, that might not be possible. But they do normally keep a range of cuff sizes within the pharmacy. They should be able to deal with most people that walk in and require a blood pressure test. So how have our pharmacies been doing, and what have they been doing? Well, 89% of our pharmacies across South East London, that's 288 out of 325 of our pharmacies, are registered to deliver the service. So certainly there is capacity amongst our pharmacies to deliver the service. And certainly that capacity has been increased recently in that now that any appropriately member of the pharmacy staff can do the blood pressure checks. And there are guidance for pharmacies to get their pharmacy staff trained up. So this is non-registered pharmacy staff can also deliver the blood pressure checks under the supervision of a pharmacist. It certainly increases the capacity that pharmacies have and release some of the pressure on the pharmacists themselves in delivering the service. But they still have to be under the supervision. All the staff still have to be under the supervision of the responsible pharmacist on the site. Has to be delivered in a consultation room that meets the General Pharmaceutical Council standards. So it's a private room, a private consultation within pharmacies, and they all have that. So what have our pharmacies achieved? Well, since April this year and up to the end of August, over 44,000 blood pressure checks have been undertaken in our South East London pharmacies, which is fantastic. That's more than in any of our other London ICB. So they're doing a tremendous job in doing that. And 90% of those were actually people that they'd identified or walked into a pharmacy and asked for a blood pressure check. So 90% of those checks were actually walk-ins, and with a smaller number being those referred from a general practice. And pharmacies themselves doing a fair amount of work in trying to identify and target people and make this service known to people. They have posters, leaflets. They're also using opportunities to put leaflets and inserts into their prescription bags and also talk to people as they deliver their prescriptions to them, as they collect their prescriptions. Frontline counter staff again play an important role in identifying, and it's important that pharmacies work with all their pharmacy staff to make sure that they are geared up and clued up about the service and be able to identify people and talk to them about initially about what the importance is about blood pressure checks and tell them about the service as well. There are promotional resources that the pharmacies have access to. Community Pharmacy England and the NHS produces leaflets and posters, and most pharmacies will have these up. There's a range of different posters that they can use with different messages on there, but the key message about understanding that the need to have the blood pressure checked for various parts of the population, but also that they can access the service through a community pharmacy. Residents themselves can actually find quite easily where a pharmacy or locate a pharmacy that provides a service. There is a find a pharmacy a service on the website that allows them to put their postcode in, either where they work or where they live, and it'll tell them the nearest pharmacies that are available to undertake the service. Also, as they go into the link, it'll tell them a little bit more about what the blood pressure check service in a pharmacy is and how to access it. Just going on to what our pharmacies have achieved, as I mentioned earlier, 44,000 blood pressure checks in the last few months since April to August, and that's the London picture. And certainly our pharmacies in South East London have been delivering a tremendous amount of checks out there, which is fantastic. From the perspective of how they've done in South East London, you'll see following the call from the delivery plan to recover access to primary care, you can see the pharmacies have certainly responded to that. You can see from December onwards, there's been a significant increase in the level of checks that pharmacies have been undertaking, almost doubling in the last 7 or 8 months. So that's certainly our pharmacies are responding to that call from the national team to actually increase the checks that they deliver. Are they delivering checks and picking up residents in our more deprived areas? Well, this is data based on where the pharmacies themselves are located. We don't have data to tell us where the patients themselves will their own residential postcodes, but we do know the data from where the pharmacies are located, and we can see that the vast majority of checks are being done by pharmacies that are located in the more deprived of our areas. As well as the clinic blood pressure checks, they're also doing ABPM, ambulatory blood pressure monitoring checks. Certainly we'd like them to do more. This is the picture across London, and you can see that South East London, we've done over 2,000 or over 3,000 ABPM checks. 2,000 of those are referred from general practice. You'll see that North East London has done significantly more ABPM checks that were referred from general practice. Certainly there's an opportunity here, I think, to do more referrals from general practice to community pharmacies to relieve some of the workload on general practice. And certainly there's a half a dozen pharmacies in Bromley that have been doing a larger number of ABPM checks that have been referred from general practice. When I've contacted them, they've been clear that they've managed to achieve that because they've done local engagement and actively worked with their general practices locally to discuss and agree the benefits for both themselves, their patients, and also the practice in referring patients to them. So I think there's opportunities for more collaborative working between our pharmacies and general practice and getting more referrals through to our pharmacies from that end. Pharmacies have a little bit more work to do in ABPM follow-ups. This is where pharmacies do an initial blood pressure check and the results show a high blood pressure check and needs to be followed up by an ambulatory blood pressure monitoring check as well. We're reaching about 20% of those patients that would need an ABPM check in the pharmacy being actually followed up. I think there's still a bit more work to do and try and get more of those patients followed up where they've actually the initial check shows that they have a potentially are hypertensive. They do need an ABPM follow-up with that. So what can we do to increase access and delivery from community pharmacies? Certainly from the pharmacy perspective, more active promotion by pharmacies. I think there's still more work to do from an ICB level to have sustained promotion of services to residents as well. Pharmacies, I think there's still more work to do in trying to getting more of their staff members trained up, and maybe Raj can come in with that. But there is certainly more opportunity to get more staff members within pharmacies and non-registered staff members trained up to deliver service. There is also opportunity to deliver clinics off-site, but it requires the consent of the commissioner of the NHS England and ICB. But certainly there's opportunities to work locally with pharmacies to deliver some of these blood pressure checks off-site, maybe in supermarkets or community centres locally to the pharmacy. From a general practice, they can electronically refer through EMIS local services on the EMIS clinical system, and we would encourage them to do that. I think it's an opportunity to identify, and there certainly was a slide earlier that Helen showed that the kind of targets that general practice need to reach, and certainly there'll be a number of patients on their registered population that are over 45 that have not had a blood pressure check in the last 5 years, or those patients who are being treated for hypertension but haven't had a blood pressure check in the last 12 months. And certainly there are patients within each of the practices that could be referred to pharmacists for a blood pressure check to help them meet their targets as well. It's an opportunity for practice to build links with their community pharmacy neighbourhood leads, and certainly Raj and myself can provide more details of that. And I think there's certainly far more capacity to utilise the ABPM service within pharmacies, and certainly general practice themselves could do more about promoting the pharmacy service within the surgery. Certainly we can make available the posters, leaflets electronically to them for print out and put up, and we've already provided digital screen material for displaying on their digital screens within the surgeries. Beyond the just blood pressure checks, there's a requirement for the pharmacist to actually provide a brief discussion with the patients about their lifestyle and behaviour, risk factors that impact on hypertension. And pharmacists are able to refer to stop smoking services, either their own stop smoking service within their pharmacy or a local authority commissioned one. And we have a small number of pharmacies within South East London that are providing a pharmacy health and wellbeing service that could be referred to as well. But I think there's certainly more potential. I'm linking in with the local authority public health teams to see where we can actually work together with them, and maybe potential for having direct referrals from pharmacies to locally commissioned services like the weight management services, diet services, and exercise services. I think there's a bit more potential work to do in trying to link the pharmacies up with services that may be available locally that they refer their patients to. Lastly, just to come on to the more exciting project that we have, from 2026 onwards, the new cohort of pharmacists will be prescribers as they register onto the pharmaceutical register, and many more of our existing pharmacists are taking up and becoming independent prescribers. So within the next 5 years, we'll have huge numbers of pharmacists in our community pharmacies that are registered and be able to prescribe independently. And this is where the NHS is looking as to how we can actually utilize this new cohort, this new resource that we're going to have in the coming years. So NHS England have set up Pathfinder programs or funded Pathfinder programs across all the ICBs to look at how pharmacists could actually provide a prescribing service. We've developed a model here in Southwark with 3 pharmacies and 3 general practices working within the enhanced access hub within Southwark. And this is where we're looking at a hypertension clinical pathway, and particularly looking at those patients who already have a formal diagnosis of hypertension. And you'll see the priority groups that we're targeting on this slide here. But the aim really is to identify these patients in those practices and refer them or give them the opportunity to the patients to access the community pharmacy Pathfinder service. And what pharmacists will be able to do within this service is provide a service where they can manage the hypertension of those patients and the ability to prescribe as independent prescribers. So they'll be able to write FP10 prescriptions for the patients, review their medication, change their drug therapy as needed, and provide a full complete service around their hypertension. Those particular patients that are going to be referred are going to be, they'll only have hypertension as a condition. They'll not be patients that have multiple conditions. So it's limited to patients who have just identified hypertension on there. But it'll allow pharmacists in this particular case to actually provide a much more fuller service, a much more ability to manage patients' hypertension and manage their drug therapy and change their drug therapy and their doses as needed. So I think that's an exciting future for pharmacy, and there's a number of other ICBs in the country looking at a hypertension clinical pathway. And I think within a few years we'll see community pharmacies playing a much bigger role in prescribing and managing longer term conditions. In particular, hypertension may well be one of those that comes on board quicker than the other ones. And the last slide just gives a flow diagram of what the service will look like. We're actually not far from launch in Southwark. We're probably going to be hoping to launch in November. We're just waiting on a couple of things to be finalized and approved, but we're very much ready to go and launch this within the next 3 or 4 weeks, we're hoping. Helen.
Thanks, Ash. I think there are great opportunities for practices and pharmacists to work together. For example, we know that there are large numbers of hypertensive patients that need monitoring every year. Only a proportion of those will need changes to their therapy, and it's possible you could use, for example, community pharmacy as a triage. So send all your patients through pharmacy, but arrange it with them first. Don't do it overnight. And all the ones that come back high are the ones you need to focus on. The ones that come back normal, the pharmacist will provide lifestyle advice anyway, and it does give a bit of a break on the pressure on GP practices, I think. So those are the areas where it's been working really well. I can see that Raj has said he gets quite a few referrals from the local GP requesting blood pressure checks for hypertensive patients so that they can identify those at greatest risk. Hi, Raj, you're here.
Hi. Thanks, Alan. I just wanted to add that also in South East London, we have a Making Every Contact Count service, which includes Vital 5. So we ask the Vital 5 questions, out of which blood pressure is one. So that kind of helps us to identify some patients that may have a lifestyle that kind of is nudging them into hypertensive status. So we do, if they're over 40, then we can do their blood pressure there and then. If they're under 40, then we have the discretion to provide a blood pressure check for them if we think it's high. So, I mean, that service, I think, is quite critical. It comes on the back of the legacy of the COVID hesitancy service. So it's proven to be very effective and successful in how we actually try to educate our core of the population about blood pressure and the other parts of the Vital 5. So, and in terms of training, I mean, I'm looking at training my staff to start doing blood pressure checks, not only the technician, but my frontline staff to be able to provide those, because I need to be able to use the skill mix in my pharmacy to ensure that we're able to provide that service universally, because I'm going to be honest with you, in the winter months, it's quite difficult to provide that service with the vaccinations.
I'm going to hand over to Rob now. He's probably going to introduce himself first and then take on the Q&A.
Thanks, Helen. I will introduce myself. For those who don't know me, I'm Rob McCarthy. I head up the South East London Long-Term Conditions Commissioning team. First thing I want to do is thank all those involved in the 3 presentations, which I think were incredibly interesting. It sparked a huge amount of thoughts in my head, and I think thoughts in the attendees as well, because I know there was a huge amount of traffic in the chat function. the first thing we were going to do in this Q&A, and by the way, we'll give nearly up to 2 o'clock for this because I think it's important, and I'm just going to take 90 seconds at the end to summarize, is to see whether there are any questions from attendees that haven't already been answered, I think, by some really comprehensive answers that have gone into the chat. And I'm going to ask Astrid if she's been looking and moderating to see if there are any that haven't already been answered, Astrid.
No, I think most of the questions that are in there have been responded to. There was this one from Gillian. I think Helen has answered that. That one was for Kessel, but there's some other questions as well that that we also have that I think we can ask as well.
Okay, so that's really helpful. So if there's nothing in the chat, I think we thought of some questions in advance, but I'd really just like to ask one question to Kessel colleagues and one question to community pharmacy colleagues, if that's all right. So my first question to Kessel colleagues, and I'll give the other question as well, and then you can both hopefully give sort of a couple of minute answers to them. From all your hard work with practices, and particularly thinking about those who have seen the best turnaround in performance, are there kind of 2 or 3 critical things that they've all done? Presumably you've captured that and more in the resource guide, which I would definitely recommend everyone has a look at because I think they're absolutely fantastic resources. But are there 2 or 3 critical things that you think are almost key turnaround points for practices who really want to shift their performance? So that's to Kessel colleagues. And then to Raj and Ash, really interested by your talk. The huge amount of walk-ins that are coming into you, which is brilliant. That is brilliant in terms of detection. But thinking, how can we improve GP referrals, and almost thinking about that brilliant example you gave the Bromley practices? How can we learn from that example and try and drive up GP referrals to help to get better blood control across South East London? So they're my 2 questions. Shall I go to Margaret and Sian first, and then come to Ash and Raj?
Margaret, do you want to go?
Yeah, exactly. So I think there's a couple of things. I think one is around the consistency of approach and the capacity of approach in general practice. So I'll expand on what I mean. So in terms of consistency, oftentimes in general practice, we're all very busy. So sometimes no one's really thinking about the bigger picture and actually trying to make sure we've really given the patient a really good understanding of what hypertension is and how it presents and why they might not have symptoms and why they should take their tablets, and really making sure you've done that bit really well so the patient's brought into sort of what the ask is of them. And then I think within that, and this links to capacity, is actually setting up a clear process in the practice of how things should work. Because I think most of the time what happens, it's kind of like if the patient turns up, we'll treat them. But if they don't turn up, we're not always looking for them. And actually the practices that I've seen the biggest improvement of the practices where they kind of really double down on their call and recall processes. They might have an administrator who's like overseeing potentially the blood pressure quaff requirements and actually making sure that recall happens. And I think linked with that, it's been successful for almost all practices, although I appreciate some practices don't like this, what I'm going to suggest, but actually having a blood pressure machine in reception makes access to getting your blood pressure checked much easier, and as well as utilization of the community pharmacy services as well. So a lot of GP practices have actually sent out mass texts or send out texts in sort of batches to say, actually, can you use the pod in reception, or can you go to your community pharmacy to get your blood pressure checked? Can you also do your blood test, and then someone's going to review you on XYZ date, and just trying to take all the faff, as it were, out of that process so it's really streamlined for the patient to engage. So I think those are a couple of the things that I've certainly noticed when talking to practices, and there have certainly within my borough been quite a few practices that have jumped up quite dramatically. And I shouldn't forget to as well mention the work of our facilitators, because actually sometimes having our facilitators go into the practices, spend a few sessions with the admin or with the practice manager, trying to understand what they think the blockers are and how we can improve that seems to have worked really well. I don't know, Sian, if you want to add anything at all.
I'd agree with all of that. And a lot of the stuff that we've learned from practices, we have captured in that resource pack for non-clinicians, because there were so many different things that worked for different practices. We mentioned process mapping as a sort of technique for managing your synovial recovery, but process mapping is just a sensible way of just getting a few post-it notes and sitting out with the team and kind of going, where are the bits working well? There are some practices in Lambeth that have amazing results, like top of the country results, and they've also managed to reduce the gap between different ethnicities as well in performance. And some of the things they've done, they've got really clear systems, they've supported their staff, they know what they're doing, they've got good call recall, but they've done some extra little bits like train their staff up. So they run searches according to people's first language spoken, and if they haven't responded to an AccuRx, they'll either send a message in that patient's language, or they will get a member of the team who speaks that patient's language to phone them up and talk to them about it. And if that person who speaks Spanish or Swahili or whatever it is understands what an hypertension review is and why it's important, and they feel engaged in that, then they'll be able to share that with patients. So I think a really big thing is recognizing it's everybody in the team and really enabling particularly your non-clinical staff to feel empowered to within the right constraints, but feel empowered to say, look, have you had your blood pressure checked? This is why it's important. So I think those are really important, but we have captured a lot of it in that resource guide, and I have put the link in the chat.
Thanks, Sean, and thanks, Margaret. We're in danger of running over. Raj and Ash, in 60 seconds, is there anything, and apologies, is there anything that you can do? And Helen, do drop off. I know you've got a 2 o'clock, and thank you so much for chairing us.
I mean, very quickly, what works is the practice pharmacists, PSCM pharmacists working with their community pharmacists. That's the link that will get those referrals through, because I think both understand what the need is and what needs to be done. So if that can be strengthened, that works, and it's worked in Bromley because I think our ABPMs are really high. So the evidence is if you get the PCM practice pharmacists working with their local community pharmacists, that will get the referrals up.
In 20 seconds, I would say that EMIS searches identify the patients from practice end, but then before sending them all through, link in with the pharmacy to make sure the capacity is there and engage and locally make that work. I think it needs a little bit of local coordination. Find the patients on your EMIS system, use the searches, and then work with local pharmacies to refer them across in a coordinated manner. What you don't want is to send them all through and then they get bounced back.
Thanks, Ash. Thanks, Raj. I think, firstly, thank you to all the presenters again, and thank you to everyone for turning up. It was an hour in the middle of a busy day. I really hope that you found there was some useful stuff in here. I think there was. There's certainly a lot that I will be reflecting on with my team. I think there's not a single silver bullet solution, but we've heard some really practical steps that might help. And in the chat, there's some really good links to resources that can help. We've had 2 partners come and talk to us that can offer huge solutions potentially to us. And I think the one thing that I would want all of us to take away is to think, what is the 1 or 2 things that I can do that I've heard today that I can take back to my practice or my place of work and think about actually implementing to try and improve blood pressure control in South East London. Thank you all so much for your time. We do hope to do another one of these in the new calendar year, because I think they're really working. And I hope everyone has a great rest of day. And thank you so much for joining. And I'll let you all go.
Thank you. Good afternoon.
Take care, everyone.